So welcome to everybody online as well. I know for some of you it's evening. Dorothy is joining us. Dorothy Dow, one of our panelists from Moshi, Tanzania. Good evening to you, Dorothy. And today, for the first of these Think Globals of the year, we really wanted to look at and talk about the HIV response, global response to the pandemic, and where it's going. And this was precipitated, for those of you who have not followed this, in that we have had HIV through the PEPFAR program and the Global Fund program by the HCV and malaria has been the single best funded disease in history. And the US has contributed more money to this single disease than any other disease. That began in 2003 with George Bush. And it has been literally many, many tens of billions of dollars over. But last year, for the first time, we did not have a reauthorization. It's reauthorized every 5 years. Instead, we had a 1-year reauthorization. It expires in March. That means the outcome of the upcoming election is going to have a very big footprint on what happens with the reauthorization. And there's really a concern that the enthusiasm and support, and donor support, and the engagement around HIV/AIDS is threatened. And at the same time, I'm going to show you some science that really shows us why the AIDS epidemic is not over, and it is not on a trajectory to be over. And that is super important. We are delighted today to have a panel to help us think through and talk through these issues. I will just briefly introduce them, and then I'm going to jump into just a few data slides, because I think we love data, right? And it's super important to have everybody sort of understanding where we are together in that background. So to my right is Dr. Jirair Ratevosian. Jirair is the inaugural Hock Fellow on our Hock Professorship in Global HIV Policy. He's based in DC, where he lives, and is at Duke DC there. Jirair's had an extraordinary career. I won't go into all of it, but I will tell you that he just recently ran for Congress. He's been a chief of staff to PEPFAR, so he's been in the administration, but he also was a legislative aide to Barbara Lee when she chaired the Congressional Black Caucus and the Congressional AIDS Caucus and helped write legislation that funded all of this. So he's really been throughout the government. And then in his spare time, he did a DRPH with me. So Dorothy Dow is known to all of you. She's a faculty member at DGHI, but also in pediatrics. She's based in Moshi, Tanzania. She's our in-country lead for DGHI collaborations in Tanzania, along with Matt Rubach, and she is doing and has done really important work on adolescent pediatric HIV. Why we asked her to participate. And then Emily Gibbons is with us, who is a senior policy person at Gilead and oversees their global access program. So we're very fortunate to have her because, as you will see, access to global goods and commodities, including the new antivirals, is going to determine where we go in the future. So can I have the first slide, please? Dorothy and Emily are going to vanish. So they're not in the way of the slides, but they're there, as is the online one. Sure. So there's a couple of take-home messages, and I often like to start with take-home messages because if you don't remember anything else, it's helpful to think about these. First of all, we have been following 2025 targets for the last 5 years. Those are laid out by UNAIDS and agreed upon by the donor countries. And we are not on track to meet those targets. We were not on track before COVID. And then, of course, COVID had major setbacks and implications for many programs. And we are not going to meet the 2030 targets on the trajectory that we're on. The 2030 target, just so you know, is that we're supposed to have the end of AIDS as a global public health problem by 2030, which is only about 5.5 years. We are not on that trajectory. The main reason for that is because new infections continue to be at much too high a rate. I'll show you that data. It's incidence that is our biggest challenge. Right? This is the 2025 target on incidence. You see that little red dot? That's where we're supposed to be going. And as you can see, we are nowhere near on that trajectory. That's the epidemic curve of the entire global AIDS pandemic from the millions. Just going to go back for a second. To add that one of the reasons why we are not doing as well as we need to be is that incidence is driven very significantly by the social determinants of health. And the social determinants of health have proven to be incredibly stubborn. Jirair is a great expert in that area, so we're going to ask him to elucidate on that. But just to say, there really are two different epidemics that are both out of control. One is a global epidemic in men who have sex with men and trans persons. That is happening in almost every country, including this one. And the second is a very concentrated epidemic in women and girls in sub-Saharan Africa. And both of those remain with much too high incidence to achieve epidemic. And obviously, the responses to those two epidemics, by definition, have to be quite different. So that's the incidence curve. That's the target that we're not going to meet. This is the most recent data up through 2023 that UNAIDS has put out. These are new infections globally. We were supposed to be by now at 500,000. That was the goal. So we're at over 1.3 million. The range is quite broad, as you can see there, from 1 million to 1.7 million. But however the estimates are, whether they're high or low, the fact of the matter is we are not on a trajectory for success. And very importantly, of these regions, 3 of them are still seeing epidemic expansion. The HIV epidemic is expanding in 3 regions globally. So it's increasing in incidence and prevalence. And those 3 regions are Eastern Europe and Central Asia, predominantly driven by Russia and Ukraine, but largely by Russia. The Middle East and North Africa, which is a very challenging region to operate in, a lot of social and political reasons. It's from a low baseline, but nevertheless expanding. And now just in the last 2 years, unfortunately, Latin America, particularly Central and South America, have joined the list of regions where the epidemic is back in expansion. So that's not good news. And it means that for those of you, particularly the students who are here who are interested in HIV, you will have a career, okay? Because this is not going away. Now we have some new tools, and Emily, as I said, is with Gilead and is a real expert on global access. She's going to talk to us about that. But one of those tools is PrEP, pre-exposure prophylaxis, right? The use of antiviral drugs to prevent acquisition in uninfected people. These are the PrEP targets. Again, those are the red dots by region, and that's where we were up through 2024. And as you can see, really nowhere close to where we need to be to meet those PrEP targets. This is some more recent data from Prevention Wire, which is put out by the AIDS Vaccine Advocacy Coalition. Sorry, it's a kind of a complicated slide. It may be better looking here. But just to say, oral PrEP initiations are in red, and they look like we're finally on an uplifting trajectory. But here's the Achilles heel. Starting on PrEP and using PrEP effectively are 2 radically different. And what we have seen again and again, particularly for women and girls, is that a significant proportion, almost a quarter, don't stay on it longer than a month. Maybe they never take their first dose. And by the end of the year, you're under 10% of people on it. And you have to be on it through your risk period in life for it to make a difference. So we're still in trouble on that. Now, this is the most recent global funding for the global AIDS pandemic from the Kaiser Family Foundation. They track this very carefully. And you can see the most recent numbers have gone from about 8 billion to a little under 8. So that is a dip. But this is largely supported by PEPFAR and the Global Fund. And so that's why we're so concerned that we may be on a downward trajectory of funding. However, lots of other people working in lots of other diseases have a certain kind of HIV/AIDS envy, because this is a huge amount of funding. still remains, as I said, the largest single commitment to a disease. So I just want to show you a little bit of data that is not modeled, but is rather from the most recent HIV vaccine trial in Africa, HVTN 702, which was done entirely in women and girls in sub-Saharan Africa. The reason for that is that's the only place where the incidence is high enough in women to be able to do trials with an HIV endpoint. So that's why it was done there. There's a lot of enthusiasm about this vaccine. And the trial, unfortunately, was stopped early for futility. The vaccine had no effect at all. This is a Kaplan-Meier curve. Everybody, if you're not already familiar with these, you will be. And this is the difference between vaccine and placebo. Those are the blue and red lines. And somebody interpret this for me. What are you seeing there? Charlie.
Well, the vaccine is doing worse at the very end, but it's kind of flipping back and forth between the two. There's no effect.
No effect.
Basically.
Yes, it's dishwater.
Yeah.
Unfortunate. But this is the critical thing. These people all had the Cadillac of prevention, right? They get regular HIV testing, they get their bacterial STIs treated, they're given free condoms. They have everything that is really in the best prevention package we can offer. And what you're seeing there is very high rates of infection. And this is splitting it out between men and women. And for women, the incidence is over 4% per year. Okay? That gives you a lifetime acquisition probability of over 30%. 30% of these women and girls will become HIV infected in their reproductive life. Stayed on this trajectory. This is not ancient history. This is the most recent trial we've done. And what it shows you is that incidence, as I said, remains a huge problem. This is what HIV looks like in the United States. The darker the color, the higher the prevalence. This is among Black, gay, and bisexual men. And as you can see, we are in the center of the United States. This is what incidence looks like. And I'll just say that there's an enormous disparity here. So the orange line you're seeing up there is HIV infections in white gay men, coming down beautifully. That is because of PrEP. The Black African-American MSM are that purple line. As you can see, it's really not budging. And then there's a turquoise line there that's rising, and that is Latinx men of same. And as I said, that epidemic is expanding in the US, and it's expanding in South. And I just want to end this by saying, of course, a lot of this is because of the challenges of our public health system, the lack of a national health system, the challenges we have in providing the basics of healthcare to American citizens. And what you're looking at here is recent data. It's an MMWR, morbidity and mortality report from the CDC, on congenital syphilis, a completely preventable and curable disease in the United States. And we have had a 10-fold increase in the last decade. That is a failure of public health. It's a failure of global health. And as long as you have syphilis rising at that level, the idea that we're going to control HIV, Nathan can back me up here, is a fantasy. So with that, let's turn off the slides and bring our panelists back. Let me begin with, I've already done the introduction. So the first round of questions, Dorothy, can I come to you?
Sure.
So the first question really is about the interventions and the global HIV targets and their relationship with mental health. We've been doing a lot of work in this area. I wonder if you would just briefly speculate on how we're doing with mental health interventions, particularly for adolescents, and you know how you see that in terms of the response in Tanzania, or if you want to speak more broadly, please do.
Sure. Yeah. Thanks for having me on this panel. It's really exciting. I guess I'll start by saying, obviously, I think the importance of mental health in the HIV response is critical and has really been overlooked for quite some time. I was really thrilled to read a perspective article that came out in the New England Journal of Medicine last year by Dr. John Nkengasong and Catherine Godfrey, where they really recognized the importance of mental health and focusing on mental health in PEPFAR programs. I think that's the first time we've really heard a strong voice in this sort of programmatic space. And they really eloquently describe data on prevalence of depression and really going beyond depression, but encompassing other common mental disorders like anxiety, substance misuse, suicidality, post-traumatic stress, all of these which are really often unrecognized and untreated. And we have strong data that suggests these are negatively impact HIV outcomes. We also have learned, I think, over time, this bilateral nature of HIV and mental health, that people with untreated mental health challenges often are at increased risk of acquiring HIV because of potentially higher risk behaviors. And those who live with HIV often have higher risk of having a mental health disorder. And so addressing mental health challenges, I think, is important both towards improving HIV treatment, but also prevention. As Chris mentioned, I'm trained in infectious diseases, pediatric ID, but in the HIV clinics, both at Duke and in Tanzania, where I'm based now, the mental health gap in HIV care just was really clear to me. And after a lot of thoughtful consideration, I decided to really shift my field of research towards addressing the mental health care gap. And so together with youth who live with HIV here in Tanzania and with mental health professionals, we co-designed an intervention that's called Sauti ya Vijana, or the Voice of Youth in Tanzania. It's delivered in groups because there is such a high burden. And this is a community where sharing experiences and normalizing those experiences has been really valuable. That those groups are led by trained peer leaders who receive weekly supervision by a local counselor. And we've just had some really amazing success in addressing mental health needs through this type of strategy. But inevitably, I do think integration into routine care is how these interventions are going to be sustained. And so I think that's the big dilemma now, not just in Tanzania, but even at Duke, this is still a problem. We don't have integrated mental health care in our HIV clinics. But I think task sharing is really a critical strategy here. That's sharing treatment delivery by training sort of paraprofessionals or lay counselors and supervising them to provide the mental health therapy. You can do this with effective psychotherapy like cognitive behavioral therapy and problem solving. Introducing new coping strategies to promote mental wellness. And I would argue that sometimes, especially for youth, these peer leaders are even more effective than going to, say, a psychologist or a psychiatrist, just because they're more approachable. Youth are more willing to share experiences. And so I think integrating that cadre of workers to address the mental health challenges is really going to be critical. So I think there's plenty of evidence to show that improving mental health can and will lead to improved adherence and viral suppression. And just to say, as the motto that hopefully we all know is, there is no health without mental health. And I think we have a lot of data that really brings this to bear with respect to HIV.
Yeah, beautifully said. Emily, thank you for being here. Emily is at a WHO meeting in Geneva today. And I want to talk with you about innovation and access, which I know is something you spent 20 odd years working on. Yeah. In particular, because in the field, for those of you who are not following this closely, we've just had 2 trials in a row, Purpose 1 and Purpose 2, of Gilead's long-acting injectable antiviral. Incredible efficacy, and it's 2 injections a year to essentially protect against HIV. And presumably Gilead will file soon with the FDA. We hope that goes well. But then it's going to be the huge challenge of access. So, love you to speculate a little bit about the innovation and the access aspect without trouble with the company.
No, not at all. And thank you so much for having me. It's really great to see you, Chris and Jirair, online, though you're very small on my computer screen, but I see the blue tablecloth. So anyway, really happy to be here, really exciting topic. And it's nice for me to get to talk to global health students. I was in grad school a long time ago, over 15 years ago, and I went at night, and it was a master's in public policy with a focus on health policy. And my very last semester of grad school, I took a class in global health, and there weren't a lot of global health classes back then. And it kind of changed my career. I was working on Capitol Hill and got really excited about what I learned in that class and took it to the member of Congress that I was working on. And Jirair and I both worked on Capitol Hill. And so I think that it's just incredible that you early in your academic careers are getting the opportunity to learn about how to make a difference in the world. So anyway, back to the drug. Yes, I can take no credit for it. I'm not a scientist. I'm a policy advisor, but pretty exceptional results. And earlier in my career, I actually worked at PEPFAR for 6 years. And I remember back then, and I came in 5 years into PEPFAR or a little bit longer. And at that point, we were just hoping to get 6 million people on treatment. That was the blue sky. We certainly, it was early on. People were, I think, just learning about treatment as prevention. And so the tools were pretty limited. There were condoms, there's voluntary medical male circumcision, and then of course, like the understanding about treatment as prevention. But I couldn't have imagined when I worked at PEPFAR that we would have the opportunity to have this incredible scientific innovation, which I've learned now being at Gilead is, 16 years in the making. It's a lot of investment to get to this exciting opportunity. But I would say, yes, so what Chris said, there was a purpose trial that was focused on adolescent girls and young women, 100% efficacy. There was a recent trial with MSM and transgendered, only 2 infections over more than 2,000 people in the study cohort. So like just pretty incredible. But I think now the responsibility is really on Gilead, but also the global partners in making sure that this incredible innovation gets to people. And I think Chris showed those slides at the beginning. We know that the burden of disease is primarily in sub-Saharan Africa, and of course, some other regions as well. But I think looking at when we think as a company about having this incredible innovation, but then the responsibility that goes with it. First and foremost, that means getting it to the people where there's most burden. And so I will say, most of my career was in government. I worked on the US Congress, and then I worked at the State Department. And being in the private sector, I think something that has been clear over the past 5 years that I've been in the private sector is launch sequences for drugs. So when drugs usually come to market and they go for FDA approval, and then you kind of determine the pricing, and then you determine kind of which region you're going to file in, and usually countries in LMIC are like the last stop, and that's a fact. And it's not right, but it has been kind of the pattern, and that's in part because companies have scarce resources and they determine where they want to put their regulatory teams. But I think early on at Gilead, it's a virology company at its core. It's a public health company. There's an understanding that if this did work, that it would have to be very, very different. And like the old model was had to be thrown out. So I can say that for the past probably 15, 16 months, we've been in really active conversations with community. So first of all, we had community kind of help us design our clinical trials. We actually allowed women who became pregnant to stay in clinical trials, which is a big deal because that's the real world. So I think from the very beginning, from designing the trials, but then going to developing the access program, we've been pretty lockstep with community and with the donors, PEPFAR, Global Fund, and also the other kind of bodies that have important roles, including UNAIDS and UNITAID and so many that I'm sure you've talked about in this class. And I think some of the things that came up over and over and over again were when we said to people, okay, like what do you most want to see? And of course, for those of you who know, we're going to be the second long-acting injectable to market. ViiV has a product which is in every 2 months. Ours will be every 6 months. And what they said over and over again is, you got to have speed, the price has to be right, the volume has to be high, and you have to be able to implement it correctly. So like you as a company have a role in not just innovating and kind of washing your hands, like you really need to make sure you're thinking about those 4 key principles. And I think that's what's really guided our access program. So when our Purpose 1 results were announced in June, the same day we announced our access plan. And this is kind of a 2-step process. One, people are not getting the leftovers. From day 1, we are going to have ring-fenced dedicated supply for low and middle income countries. They are not going to get the spoils of what the US or Europe didn't want. We're going to have our own supply. And secondly, we're going to supply as long as it's needed, but right away we're going to be signing voluntary licenses, basically allowing generics to have our IP so that they can bring lower cost versions of our drug to market. So very clear about saying, we don't want you to wait 3 years. We'll be in it as long as you need us, but then we're also going to make sure that we're working with these generics, and those will be signed this fall. And then, you know, of course, having a really aggressive regulatory filing plan that prioritizes, of course, the FDA, but also working with different regulatory bodies in Europe and NRAs to make sure it's getting to market. So I don't want to go on too long, but just to say, I think that we've been very intentional about saying, like, this is different. And if this product doesn't get to people, knowing the burden of the disease is mainly in PEPFAR and Global Fund supported countries, then we should be ashamed of ourselves. And I think that we've acted with integrity so far.
Thank you so much, Emily. That's really, yeah, indeed, very, very insightful. And again, specifically for the students, those 4 elements of rapid access, that is a roadmap for the future. That's critically expected. But of course, from the beginning with the HIV/AIDS epidemic, we've had inequalities. We've had structural inequalities. We're still dealing with many populations in many communities that are criminalized in many countries, that are marginalized, excluded from healthcare. And Jirair, you've spent, you know, really so many years working on these challenges. I wonder if you can reflect on where we are from that aspect of the epidemic. And what the prospects are, because it remains, these multiple challenges really remain barriers.
Yeah, the hardest frontier, I guess, coming up. Well, thank you, Chris. Thanks for that question. It's good to be with you all. And we have 58 people on the Zoom as well. Thanks to
awesome.
those of you who have dialed in, and keep your questions coming, because we'll get to them in a few minutes. Chris, you said it earlier, you know, with regards to the social determinants of health, and that's what it all comes down to. We've had tremendous progress. I also worked at the PEPFAR program that Emily mentioned for a couple of years, and just this past year, PEPFAR announced that they've saved 25 million lives. The U.S. taxpayer support has saved 25 million lives over the past 20 years. And as we look to 2030, as Chris said, we're 5.5 years out from these global goals. Closing those gaps are the hardest, the gaps that remain, including gender inequality gaps, including gaps with marginalized populations, as we saw. And a lot of it goes back to determinants for health. So let's unpack that a bit. Income inequality, and we're talking mostly about low and middle income countries now. It's still very, very pervasive all across a lot of countries where global HIV programs are operating. Poverty, lack of jobs contribute to people's inability to access healthcare. It leads to people engaging in transactional sex. These activities lead to HIV vulnerability, and that is a cycle that continues in all parts of the world. Chris showed where new infections are increasing, and a lot of it goes back to where there's increased vulnerability for HIV based on structural barriers. Laws and policies are a major hurdle that continue to lead to more vulnerability, in particular for men who have sex with men, for sex workers, transgender people, and people who use drugs. Many countries, over 50 countries, still criminalize these populations. And this is not just something that's archaic. Even this year, we saw the Uganda Parliament actually pass a new law criminalizing same-sex relations. And so if you're a gay man in Kampala, Uganda, you're not going to go to the healthcare setting to access care because you're scared to talk about your sexuality, you're scared to engage in a healthcare service, and that leads to more HIV vulnerability. So these laws are very much being updated in many capitals around the world. Even in our own Supreme Court, we're seeing a backsliding in laws that protect LGBTQ plus people, that even give women access to reproductive care. So all of these issues as it relates to laws and policies very much relate to increasing HIV vulnerability and moving back progress. There are also a number of regular healthcare access issues that we haven't been able to solve. I oversaw the South Africa program for PEPFAR, and South Africa has the largest program, over $500 million a year goes to the HIV program in South Africa. And in many rural settings, people still have to travel 4 or 5 hours to access a healthcare setting. They go to the clinic and there's a 4-hour wait. Can you imagine if you just took a bus or in some instances, mothers walking to these clinics, and then you get to the clinic after 4 hours and there's another 4 or 5 hour wait. It's now, I don't know, 10 p.m. and you still haven't been seen by a healthcare provider. Of course, I'm giving the most dramatic example, but these are examples that community-led monitoring elucidate every single day. And oftentimes, stigma and discrimination is also something that healthcare providers and healthcare setting still very much experience, and that leads people to be turned away from health services. So we have the innovation, as Emily described, but we need to get the implementation right. And a lot of that is about focusing on the structural barriers, focusing on the policies, focusing on income inequality, gender inequality, and all of these issues are what global health programs, and in particular HIV programs, are now focused on. PEPFAR just announced an equity initiative to specifically fund and intentionally scale programs that look at vulnerabilities of women and girls, vulnerabilities of children, and these key populations that I mentioned that are increasingly being vulnerable to HIV. So progress is to be celebrated, but the next frontier, so to speak, is going to be the hardest. And as you said initially, Chris, it could hold back the entire response if we don't get the exact help that's going.
I've been really impressed with the persistence of HIV, you know. And there was, if you remember, a period, and Emily, you may remember this from PEPFAR as well, the idea that once we finally got treatment available in low and middle income countries, that was going to have a huge impact on reducing stigma because people were going to live longer and do better. And it just hasn't happened, to the extent that we wanted it to. And there's a whole, of course, new sort of frontier of stigma innovations and interventions, but it's not going to go away passively. It really is going to be an area of very active engagement. I want to just pick up, Dorothy, on what Jirair was saying about children, the pediatric populations. I think, you know, if we look across the landscape, one of the most successful areas has been the prevention of mother-to-child transmission. And, you know, in the US, for example, we have fewer than 50 HIV-infected births a year. It's essentially become eradicated, which is awesome. But we haven't done anywhere near as well with children new treatment. And certainly adolescents, I think, are probably the population we're most concerned about, particularly because for those of you who have demographic interests, we have the world's largest cohort, the largest cohort of adolescents in human history is the adolescents who are alive today. It's an enormous youth bulge, and the biggest youth bulge is Africa. So maybe you could speak a little bit more to the challenges for adolescents. Yeah, we can't hear you, Dorothy.
All right.
Oh, there you go.
Can you hear me now?
Yes.
Okay, thanks. Sorry about that. Yeah, totally. I think PMTCT has been a huge success, and that was my original area of research. And just to say, yes, we have very few infections in the US, but it's still shameful that we have any at all. And I took care of the one Duke infant that was infected, I guess, about 1.5 years ago now. And, you know, it shows the cracks in the system. So to your point, we're not done. But it has been a huge success story. I did pivot to the adolescents for many of the reasons that you're claiming. But, you know, we have seen this sort of plateau, if you will, of our effect in PMTCT. So just to plug that our success is stifled. There's still 120,000 children infected last year. it's just not acceptable. And I think the adolescents and the young women are those who are becoming pregnant, who are not getting the care they need. And that's just sort of perpetuating, you know, what we're seeing in the epidemic. So we have to do better. And as you're saying, I think stigma is a huge part of this, the gaps in testing and treatment, obviously, and specifically for the adolescent young adult population, as we call IAs, we talked about mental health already, but that's a huge crisis. I won't go back into that. I think we do have better tools. We've had intensified efforts around the adolescent girls and young women population. 50% reduction in new infections in the last decade. That should be celebrated, as Jirair is saying, but still adolescent girls and young women are 3 times more likely to be infected. They're still fueling this epidemic, and we're not there yet. So programs like PEPFAR Dreams that aim to really address these disparities through programs that keep adolescent girls and young women in school, keep them HIV uninfected are hugely important. Addressing, as Jirair mentioned, gender inequalities, gender-based violence, all these things are critical, but I would absolutely argue PrEP is going to be the key here. You've already mentioned this, Chris, that oral PrEP can be highly effective, but you have to take it. And we know in this population, it's essentially ineffective. And so now we're entering this super exciting time that Emily's told us about with new long-acting injectables like cabotegravir, the ViiV molecule she was describing. That's a little bit of a harder injection and it's more frequent. So I think it's really exciting that lenacapavir's, coming on board. Sub-Q is a lot easier than IM in the buttocks, I tell you, with people's willingness to take it. So getting these implementation strategies are going to be really critical. 100% effective in the adolescent girls and young women, and allowing pregnant women kind of back towards the PMT-CT cycle. I think it's critical that we don't ignore them, because that fuels the new infant exposed babies becoming infected. So I think, with PrEP, we really can see a total game changer, but we have to get these meds to the people that need them. And this is largely it's everyone, but the adolescent and young adult population is key in getting this all under control.
Yeah. Emily, I think one of the things we've seen as a barrier with oral PrEP in some countries has been that there are programs and donor funding out there for the low-income countries. And of course, often high-income countries pay full fare, and that's part of the 2-tier pricing agreement. But there are an increasing number of countries in the middle tier, right, that are not low income anymore. And that's increasingly happening in Africa as the economies expand and grow. And they often are stuck in a difficult place. They have too high a GDP to qualify for many of the donor-supported programs, but they don't have the money yet to support full fare. I just ran into this not too long ago, just before COVID. I chaired a meeting on HIV in Middle Eastern countries in Lebanon. Lebanon was absolutely stuck in this place. They could not afford PrEP. They wanted to implement it, but they were too wealthy for any of the low-income funding programs that they have. So I wonder if that is a part of the strategy as you think about rolling out lenacapavirine and how that is going to look.
Yeah, thanks. And really good question. I mean, I think, and I would say that that's an evolving part of the strategy. So certainly more to come on that. A couple of things, like, yes, absolutely. So Gilead has a 17-year history of really pioneering direct voluntary licensing, meaning that we negotiate them directly. And some people in this class may be familiar also that there's a UN-backed organization, the Medicines Patent Pool, which also can play a role in brokering licenses. Gilead has worked with both models, and we think that the MVP is particularly important for companies that don't have as much of an investment in this space. But I think to Chris's broader point, usually companies will look at kind of like they'll look at a few criteria, high burden, they'll look at GDP, World Bank income classification, and some countries will be in that license and therefore eligible for the best available price, and then some other countries won't be, where there's no doubt that there isn't a high burden of disease. And so I think that's a challenging public policy problem, because I think, you know, companies they do need to make sure that they're making kind of choices of how they're using resources. And I think that Gilead, again, has been a pioneer in having broader voluntary licenses for country scope than some countries. But I think other models that we've looked at is tiered pricing. So, you know, maybe the United States is eligible for one price, Europe is eligible for one price, and then some of these middle and upper middle income countries have a different price. So that's, I suspect, a model that will be employed, but we haven't really addressed that specifically about this specific product. But it is really important to think about when you're developing an access program and when kind of donors, but also kind of other organizations and NGOs are working together to understand the burden of disease. I think that Gilead, with its long history in virology, has looked at some of the different public-private partnerships where it could be value add. And one of the places that we've actually invested a lot of resources in is Eastern Europe and Central Asia. So as I think Chris mentioned earlier, when he was going through kind of the geographic context of the burden of disease, because of Russia and because of its incredibly onerous policies, there's been a surge of infections in Eastern Europe and Central Asia, in part also due to the fact that a lot of people that might be more vulnerable don't feel safe in these communities and don't feel that they can actually access government services or NGO services without fear or persecution or harm or criminality. So Gilead has worked in those kind of country contexts and not kind of prescribed a solution, because that's not our role, but worked very closely with NGOs to say, we can see the burden of disease is rising. How can an organization like Elton John, which we partnered with on Radiant, and how can other NGOs kind of bring their specific equities to the table and help advance public health impact in a way that we might not traditionally through our commercial programs. So that's something that we've employed over many, many years as well.
Yeah, Russia's a great example there, because of course they were part of the G8 agreement. They pay full fare, not that they can really afford that, and their health system is really challenged by it. But also, the most recent data we have, at least what they've reported to UNAIDS, is that their rates of viral suppression are only about 40% of people in Russia living with HIV, which is worse than any of the PEPFAR countries in sub-Saharan Africa. That is really, it's a crime, actually.
And you can see that spillover effect, of course, like those policies that Russia pursues, like just have this, infectious disease knows no borders, and it just has had a really debilitating effect on countries that surround it.
The last question is for you, Jirair, and then we'll open it up for everybody. We'll have hopefully about 10 minutes or so for questions. And the last one is just to get back to the point about PEPFAR reauthorization and the challenges that we're facing in terms of funding and sustaining the global response. You've been on the Hill in these fights, and you've been in the administration in these fights. What does the landscape look like? And there's some debate about because we're not going to have a reauthorization until after the election, that we may, the election may play a very big role in whether or not PEPFAR is reauthorized.
Yeah. Well, thanks for that. Is the, I was going to say million, but it's the $1 billion question.
It's $1 billion, multi-billion-dollar question.
When I think of what makes a successful program for members of Congress, and Emily and I have worked for members of Congress, it is a great career path if anybody's interested in health policy to intern and to work for your elected officials. There are a few things that are hallmarks of a successful program. There's data, there's impact, and innovation, right? If you get those three right, And of course, you have to get the politics right. And that leads to multiple years of successful, as we call reauthorizations, which is when Congress passes a new law to increase the funding or to increase its authorization. And that's, as Chris said, has happened 3 times for PEPFAR. And usually when they do that, they reauthorize the program for 5 years, and they extend the billions of dollars that go into it. And PEPFAR and Global Fund working together, they have really taken all of these, they've taken data, they have some of the most robust data systems online. You can go to pepfar.data.gov, put in countries, put in counties, and you can get granular level data. And they take this data and they educate members of Congress about how the impact that their programs are having and the programs that the members of Congress are supporting are having and why it matters to them. And that storytelling is what we've done for the past 20 years. Innovation is also really is important because that allows the program to be adaptable. We talked about innovations today, including long acting, as Emily mentioned. If these programs are not able to absorb new innovations, change their programming to implement these new innovations, then the program becomes stale, impact is reduced, and it becomes harder to garner the support. And you have to get the politics right, and that's probably the most important. And Emily mentioned her friend Elton John, and we've had many friends that have been nice and have been advocates of the HIV program, going back to Elizabeth Taylor. And Elton John now, and Bono, and U2, and we're throwing these names out, but these people go on the Hill and they advocate and they talk to members of Congress about why these programs are so important, how they're saving lives, and why, given all of the competing priorities, including challenges that we have in our own country, with our healthcare system, should we continue to appropriate, as they say, this many billions of dollars for the HIV response? And in the last year, we haven't gotten the politics right. Yeah. And that's what led to a 1-year authorization for PEPFAR, and it's something that advocates are working on. And it means that all of us have to re-engage in the HIV response, continue to storytell like we haven't before, use digital technologies to really bring life some of the challenges that Dorothy mentioned with regards to children and mothers, bring their stories directly to members of Congress in Washington, D.C., who meet on any given day with maybe 20, 25 different constituencies. Right? So that's what we have to do. That's the work ahead of us. It takes really a broad coalition of people, not just in healthcare. We need a broad coalition of private sector, public sector, and advocates to really be telling the story. And that's what I know advocates in DC are going to do for the next few months. The authorization expires March 30th. And there's a big push now to get another 5-year reauthorization and make it bipartisan. That could have started there. To get the politics right, it needs to be bipartisan. Yeah. And we've had that for the last 20 years for the HIV response, and that has to be maintained more than ever. You've heard this Congress is a little tough Congress to work in, but even in difficult Congresses, we've been able to push a PEPFAR reauthorization. So that's the work ahead. If anybody wants to come to DC to intern, I'm happy to talk to you after class, but this is the big question for 2025 is how can we get PEPFAR to have another 5-year reauthorization, continue the support to get to the 2030 goals and way beyond.
Yeah, great. I remember, I can't remember if it was 10 years ago or 5 years ago, it was definitely before COVID, doing a Hill event with Elton John and Magic Johnson.
Yeah.
Now they're quite a pair. I mean, that was motivating. People got serious.
Another friend of Emily's.
Yeah. Indeed. So now we'd love to hear from you, ask questions. If it's for everybody to say that, if they specifically want to ask one of our terrific panelists a question, please do. And I think you're also monitoring the online.
We have one question online if you want to start there.
Yeah, sure.
Gives the folks some time to formulate.
Go ahead.
Okay.
I can't see it.
Barely saving time. There's a good question in the chat for Emily. Emily, you mentioned some of the licensing work that's ongoing now. You mentioned that Gilead is looking at bilateral licensing. Can you share a little bit more about what that approach is like historically and specifically for lenacapavir? And then are there going to be regional considerations for the kinds of license partners that Gilead might consider? And maybe say a little bit more about what that actually means, practically.
Yeah, and thanks for the question. I think it's really important. I would say again, I've been at Gilead for about 2 years, but I'm certainly well familiar with its history. And over the past 17 years has really built up an incredible expertise in voluntary licensing. And I think one of its approaches has been to make sure that there's regional diversification. But of course, you know, to the question in the chat, there are specific capabilities associated with it. But I think a lesson learned from remdesivir, which was the first COVID treatment. I think some people probably remember that there was a time period in which India had an export ban, and that was challenging because a lot of the generic companies that many pharmaceutical companies work with are located in India, and I think that really underscored the importance of having suppliers in different areas. So we have worked with suppliers in India, Pakistan, North Africa. I'll admit I have to do a little bit more Googling, but it's been important to Gilead to make sure that we're not in a scenario where if you have this, you know, desperately needed treatment like remdesivir, that there could be a scenario in which other people couldn't benefit from it. So I think early on, there's always been a focus on making sure that you have, you know, you want to have just basically the model is you want to have enough generic companies that you license with that will optimize the price, that will drive down the price, that will create competition. But you also can't have too many licenses because then there's really not a value proposition for generics to come into the market. And it's important to remember that these generic companies are businesses. They are not NGOs. They are also seeking to build their business. And so if you have too many, it might disincentivize them from really going broadly and registering in as many countries as perhaps need that impact. So we, as a company, generally look at kind of finding that sweet spot for the number of generics, making sure that they're in geographically diverse locations. And then, you know, of course, evaluating to make sure that the specific companies that we license with, you know, have longstanding relationships with WHO, know how to engage on WHO PQ and guidelines, that they meet quality standards, that they're, you know, that they'll pass inspections, because these are all important for access as well. But looking in that multifaceted approach, as I mentioned, we have been public. We announced in June that we would be signing voluntary licensing. That evaluation process of like the different generic companies that may be able to produce quality lenacapavir for PrEP is still ongoing. But I can say that those are kind of like the top line things that our company looks at when they pursue these generic agreements, which we have done for so many products across HIV and hepatitis.
Please.
Okay, so a question of endurance. If you look at, this has been going on, PEPFAR goes back to George Bush.
Yeah.
And Congress looks at that. And if you're going to persuade them that there's something exciting that's going to make a difference, it's probably going to be the availability of the injectables in order to promise an improvement in the success of this program. It's been going on and on and on. But in order for that to work, you're going to need the people who are out in the field. And is the energy still there? So this is really for Dorothy. Is the energy still there if something like the injectables becomes available to successfully implement it out in the field?
Yeah.
Like I would say 1,000% yes. I think people are really wanting this. I get asked about these every day. Why is this available, you know, in the US where you work, but not available to us here? I think implementation, to Jirair's point, is critical. You have to get it right. I mean, there's a lot, you know, there's a lot of complexity, but I think back to the George Bush days and the naysayers of, you know, we can't deliver antiretrovirals to Africa. That sounds like a crazy idea, right? Like, well, here we are, 25 million lives saved later and countless other amazing things that have happened. I think the energy is very much present. People are really wanting this, and I do think that this is what's gonna tip the tides. So I don't know if that's entirely answering your question. We cut out just a little bit, but the energy is very present. I think policymakers, I think governments, I think CBOs, the community-based organizations, I think the people who don't want to get HIV and those who live with HIV and want better alternatives, everyone wants long-acting injectables to come.
Oh, okay, let's go to Wendy and then we go back.
Okay, so I think this is a question for you, Emily. I was just thinking a little bit about the success that came through working with the private sector around injectable contraceptives. And that was really opening up that venue for women to be able to get injectable contraceptives over the counter in private venues, even retail shops, was pretty transformational. And now that you have a tool that could be used for prevention, have you thought about partnering with the private sector, since presumably this is less complicated than maintaining the continuity of care that's required for ARVs and viral suppression?
Yeah, I think it's so important to get implementation right. And I think back to, I was at PEPFAR when oral PrEP was rolled out. And I think one of the mistakes that was made is that, you know, it was a new innovation. People were a little bit nervous because PEPFAR had used all of its money to be a life-saving program. And so prevention was different. And unfortunately, oral PrEP got marketed towards sex workers or for people that were considered high risk, and it became something very stigmatizing. And so we had this great public health tool, but then we did it wrong. And then that really impacted for years to come uptake. And, you know, we're in a situation now where oral PrEP over the years, it's generic. The price is actually pretty affordable, but as Dorothy had mentioned earlier, the adherence is really low. So we have this great cheap product that people don't take. And so we've kind of, we've really gotten that wrong. And I think with long-acting injectables, Gilead is pretty open about the fact that we don't think we're like a one-size-fits-all. Like for some people, and because, you know, people often take PrEP in different cycles of their life, like oral PrEP might be the best thing for them, and they should have that option. You know, long-acting twice a year, that's really easy. So right away, you take the 2 oral loading doses, because there is a pill component, and an injection, you are protected on day 2. Like you are protected right away. So for 6 months, you know that person is protected, whereas we know that with oral PrEP, people don't even necessarily last for 6 months. So I think we really have thought a lot about how to best reach people. And we know a lot of people don't want to go to some treatment clinic. They want to go to a place that fits their needs, that fits their life, where they're not going to get judged. And so, you know, we're really excited about some of the innovations that have been made with pharmacies, and then adolescent health services. We know that that's one of the benefits of the DREAMS program, which is a multi-sectoral partnership between PEPFAR, Gilead, Johnson & Johnson, Nike Foundation, Gates. I'm going to forget them all, but just kind of that we need to reach adolescent girls and young women in a different way, which is primarily, where do they feel safe? Where do they feel like they can get the drug in a way that like makes them feel good and just is about their choice, as opposed to like that they have anything to be ashamed about. So I totally take your point on kind of the advances in reproductive health. We've actually spent a lot of time kind of looking at that data and looking at and speaking with consultants that have, because we think that there's a lot of knowledge to be found from that. And I know that PEPFAR kind of has the same perspective. So our plan, of course, is to find where we can be value add, because we have the innovation, we're working on our access plan. And then ultimately kind of the third part of Gilead's strategy is that we have corporate giving. So finding out maybe like that next big public-private partnership where we're actually making a dent in implementation. And I think what you just raised is a very good point.
Chris, we've got a couple of questions, which I know you'll like, because it's about science and data. See, there's one right here. So there's a medical student from Nigeria who's asking, a lot of research on LGBTQ issues don't differentiate between MSM and trans women. What are the implications to this? Yeah. And then there's a question about disaggregating data as it relates to adults and children. and specifically pregnant women, ages between 15 to 19 are not disaggregated. So how do we know where the hotspots are? So some good questions about science and data.
Yeah. So one of the challenges with oral prep is that there were differential outcomes by gender and also by gender identity. So, for example, cisgender women with oral Truvada, so 2-drug combination, typically need 9 days of daily oral use to be protected. Whereas men who have sex with men typically protected after 2 doses, much more. And a lot of that is just physiology. It's not about gender. It's about the fact that most of the exposure in men who have sex with men is rectal exposure, and it's an oral drug, and it has very good uptake in the gut. So it is protecting precisely the tissues that need protection. Now, the challenge with transgender women has been that there always were smaller numbers in the early trials, and so it's hard to analyze the subset data, but it was consistent. So remember, these are people who are assigned male sex at birth and have a female gender expression, right? So physiologically, they generally are not differentiated from men who have sex with men, but the adherence issues were always more challenging in this group, and the data suggested that oral prep wasn't working. One of the innovations with what Gilead has done with these 2 purpose trials, and this is really important, is first of all that the first trial was done in cisgender women and girls. Usually women have come last in these trials, so that's an innovation. But secondly, that women were allowed to enter the trial if they weren't using contraception, and if they became pregnant, they could stay in the trial. That was always never allowed earlier. So that's very important, because this is really the first where we actually have data on the efficacy and safety of the drug in pregnancy. There were a number of pregnancies. And finally, I will say that Purpose 2, which was done in multiple countries, I think, Emily, you'll know exactly, but it's 8 or 9 countries. It included the US, South Africa, Peru, Brazil, Mexico, Thailand. Am I getting most of them? Yeah. And that population was men who have sex with men, transgender men or women who have sex with men, and non-binary people who have sex with men. So it was the most inclusive, really, of these trials. And again, there are very few infections. There's not going to be a lot of ability to do subset analyses post hoc. These are not stratified trials. But nevertheless, the overall protection was 99.9%, which is pretty great. So all to say that one of the big changes with the long-acting injectables is that we're going to be able to get out of this challenge of having differential efficacy by gender and by sexual orientation. It was always the challenge before. Okay, well, please, last question.
Okay. So my question is a bit like more broad from the topic. It's solely on the middle income trapped countries and foreign aid. Both were mentioned during this class, and I was wondering if, so most of the foreign aid that comes from Western countries, the UNAs, focused.
Not good aid.
Okay.
Just to be clear.
Okay, so most of the Western country foreign aid kind of concentrates more on the policy recommendations or like guideline recommendations.
Yeah.
Whereas, for example, like other emerging countries, like China, for example, its foreign aid is a bit different. It's more infrastructure focused. And I was wondering if it's like around the HIV topics, would it be like more effective to offer more tangible like solutions to the problem, or has it been done already? Because like from this class, I got the impression that it was only like policy related work. And if we talk about like tangible kind of recommendations in terms of like developing infrastructure or technology, because it's usually, there's a big problem of implementing the policy, and it's a challenge for countries, especially if the policy was developed externally and not by the country directly. So I was wondering if it's on the agenda or has it been done already when like foreign aid comes in, like builds infrastructure and does the whole thing directly without the policy part of it. Yeah.
You want to take that on?
Yeah, no, it's a really good question because it's a geopolitical question in some way, right? You mentioned China's approach to foreign aid is different than the United States' approach, than other European nations have different approaches. One of the hallmarks of the PEPFAR and the HIV response and Global Fund, which contributes to why it's been so successful and well funded, is that not only are we fighting HIV, but we're actually building them. And so hundreds of thousands of clinics have been built and supported through PEPFAR. Laboratories have been built and strengthened through PEPFAR. Healthcare workers have been trained, 140,000. Don't quote me on that exact number. Have been trained through PEPFAR. This is healthcare infrastructure that didn't exist before. And that was put to test as it related to Ebola in West Africa and more recently in COVID. And so the HIV platforms, as we like to say in Washington, these platforms were put to test for other disease areas. And it illuminated for countries how the HIV partnership it has with the United States helped them fight other diseases. That's something that is actually helping. So, but it's something that more focus is needed, more health security. Concentration is something that more people want to now. People are saying, well, what else can we build on? What can we do? Mental health. Can we do
pandemic preparedness?
Yeah, and the truth is, you can. It just takes planning.
Yeah.
Well, I think we've come to the end of our time. This has been a wonderful conversation. I want to thank all of our panelists and just ask you to join me in thanking you. How nice is it to have our inaugural Hock professor with us?
Yeah, thanks, everybody. Thank you.